and it is a real pleasure. I also had no difficulty in accepting the invitation to come and speak with you at this really exciting conference. It's a real honor to be here with the real status of the Northwestern Scleroderma program led by Dr. Varga, and of course the greater Chicago chapter of the Scleroderma Foundation. So I'm going to talk to you on the state of scleroderma clinical trials, and it is an exciting time to be giving this talk, really because there has really been unprecedented effort, I think, to try and advance the available therapies for systemic sclerosis for scleroderma over the last 20 years, but especially over the last 4 or 5 years. And this has translated into much more investment, not just from the academic community, but also from the pharmaceutical industry in trying to perform high-quality clinical trials, which we all depend on to get the evidence base to move forward, to get regulatory approval, and to get access to treatments. And I think that one of the things that certainly keeps me very, very motivated is the prospect, I think, of moving to a situation where we do start to have licensed therapists specifically for systemic sclerosis. So what I wanted to do in my talk this morning is just give you a very brief introduction to the scleroderma program and the cohort of patients we look after at the Royal Free Hospital in London, to discuss a little bit about the principles and methodology of clinical trials, because that's been part of, I think, the learning that we've had in the scleroderma community over the last 2 decades to make sure we can improve the way we do clinical trials, and then really give you an overview of a selected number of trials that we've done recently, things we've learned from them, and some of the prospects for the future, including, in fact, several studies that are going to have their top-line results presented at this ACR Congress in Chicago. So we do look after a very large number of patients in our scleroderma program in London at the Royal Free Hospital and University College London. We have around 1,800 patients under regular review. We often share care with local rheumatologists so that we're not involved in every aspect of these patients' care, but this is a very important opportunity, I think, to contribute to the care of the patients, also learn from the patients and learn about the disease. And one of the things that you will appreciate is that systemic sclerosis or scleroderma is a very diverse disease, and that is true for our cohort of patients as well. And I just put up in this series of pie charts the sort of major ways that you can see that heterogeneity or diversity in our population. So we can look at our patients, these 1,800 patients under review, and we certainly see about a third of the patients have the diffuse form of scleroderma with more extensive skin involvement, and 2/3 have the more limited form of scleroderma. We know that the patients can be classified or categorized according to their autoantibody profile. This is an autoimmune disease, and we see the typical spread of antibodies, anti-centomere antibodies, anti-SCL70, anti-RNA polymerase, and other reactivities that are important in clinical practice because they can help us to predict risk of different complications. And as in other scleroderma cohorts, we recognize that the majority of our patients are female. We see certainly far more women with scleroderma, but we're also well aware that although they're in the minority, systemic sclerosis in male patients can be particularly challenging. We've been struck by the fact that about 1/5 of our patients have what's called overlap scleroderma, meaning they don't just have systemic sclerosis, but they also have another autoimmune rheumatic disease like lupus or myositis or Sjögren's, and you can see how that is divided in that 18% here. We think that's important because it means as rheumatologists we've got to manage not one but 2 conditions, but also because we can learn a lot from those patients, because of course we're understanding there are shared links in the biology and even between in the treatments that we can perhaps use from these other forms of rheumatic disease that we can perhaps repurpose for scleroderma. And the other thing that we're very well aware of is that our systemic sclerosis patients get major internal organ complications, and that's a tremendous burden, and of course that's what makes the disease particularly challenging. So Here are three of our patients in our cohort: a gentleman with very severe diffuse scleroderma, and then a case of earlier stage limited scleroderma and a later stage disease. What we are struck by, though, that whatever subgroup or subset of patients of scleroderma you are certainly at risk of the broader complications and the internal organ manifestations of the disease. And this is one of the things that makes the condition challenging to manage, but also, of course, very challenging for the purpose of clinical trials, because we're dealing with patients, of course, that have the skin involvement you saw on the previous slide, but also the digital vascular disease and digital ulcers, the vascular problems in the gut, lung fibrosis, pulmonary hypertension, renal scleroderma, heart involvement, and of course the very, very debilitating musculoskeletal disease and calcinosis. So, it would be a tall order to ask for a drug that could perhaps reverse or treat or even prevent all of these different manifestations. And that is a challenge when we're thinking about clinical trials. So there's been a lot of effort to try and think about what is the best way to test a new potential therapy in systemic sclerosis. Because of those challenges, the severity of the disease, the diversity of the problem, and the fact that that it can be very hard to know whether you're improving or impacting on complications that are sometimes hidden from easy clinical observation. So recently, a group of scleroderma experts from internationally came together to really think about what would be the best ways of doing clinical trials in scleroderma. And we published this article, which really just highlighted 22 aspects of scleroderma clinical trials about how we could improve outcomes and management. I've distilled some of those principles down into a schematic here, and this was a schematic that came from an article that I published with Dr. Barber and other colleagues, that really just summarises, I think, the current view of how we can do effective clinical trials in scleroderma, and it really takes some of those points that I've made in the previous slide. So the very fundamental thing, and I think we have had to, as a community of scleroderma investigators, had to relearn this over the last few years, is that it's very, very important when you're testing any new potential treatment for scleroderma to do it in the context of a placebo-controlled trial, meaning that you will, as part of that study, give your test medication to a group of patients, but you will also have a group of patients who receive a placebo, a dummy drug, if you like. And whilst for a long time it was considered that this may be very difficult in a disease as challenging and severe as systemic sclerosis, but also perhaps even a little bit unethical, because you would be potentially treating patients but not giving them an effective treatment. I think we've had to relearn that, and the reason why that is so important is because of the diversity of outcomes that we see in scleroderma, and for sometimes the tendency, fortunately, for the disease to even improve on its own. It can be very, very difficult to know that your treatment is effective unless you've got a control group that you can clearly show has not done as well as the patients that have received the active treatment. So the first thing we've learned is that you really need to do this sort of design where you have a parallel group where a proportion of the patients will get the active therapy and a proportion will get the placebo. You can refine that in some ways. Sometimes you can have a crossover design where for part of the trial the patients will have placebo and part of the active treatment. And you can always follow on the placebo-controlled phase with what's called an open label phase, where all patients will get access to the treatment. So these are things that are very important if we're thinking about patients entering a clinical trial and knowing at least they may get the option to get a potential new therapy. But the other thing I should point out is that not all of these trials, even when they're placebo-controlled, are controlled against no therapy at all. It's perfectly feasible to do a clinical trial where you give all of the patients standard therapy, and then you add on to that either a new drug or placebo. And so that, again, can make the trial much more feasible. So we've learned that you need to do placebo-controlled trials to really interpret the results. And I'll show you a couple of examples how we learned that from trials in the past. The other thing we've learned is that because systemic sclerosis and scleroderma and its complications are really difficult aspects, difficult things to treat or improve, you need to do the trial for long enough that you can reasonably expect there to have been a response to the treatment. And so this means really for most aspects of the disease, you need to probably treat patients for at least 12 months to see improvement or differences in things like lung fibrosis or skin involvement. You can get earlier clues that things are perhaps working, and you can use this earlier part of the trial often to do very exciting research studies to sort of understand your treatments better. But essentially you need to do placebo-controlled trials, and you need to do them for long enough that you can interpret the results and expect impact. And the other thing that we've realized is that you can't just do a one-size-fits-all trial for such a diverse disease. You need to select your patients to go into the study that are really the group that are most likely to be informative or to benefit from your treatment. So you need to think about a subset of scleroderma, whether they're at risk, for example, of lung fibrosis or pulmonary hypertension, and so on. So we've become much better, I think, at, if you like, enriching or focusing our trials that allows us to do trials in a slightly smaller, particularly in the early stages, because, of course, the challenge for scleroderma is it's a rare disease, and so you can't do clinical trials with hundreds or thousands of patients like you can in hypertension or diabetes or common medical problems. And then the final thing that I think we've learned is the sort of number of patients you do need to include to reasonably get a chance of showing the effectiveness of your therapy. And as the trials become, if you like, more close to the sort of trials that could underpin regulatory approval, you need to do larger studies. These are what are called phase 3 clinical trials, where if the trial is positive, there's a very good chance that that therapy would then get approval by health authorities and could be available in the clinic. When you do sort of these earlier studies, more exploratory studies, you can use smaller numbers of patients. But one of the things we need to think about is what is the best measure to assess as a sort of first impression that your drug is working in scleroderma. And I just want to highlight that for many years, and indeed in most of the recent trials, a really big emphasis has been on trying to assess the severity of skin involvement in systemic sclerosis patients. And the reason for this is that, of course, almost all patients with systemic sclerosis will have skin involvement. That's why it's called scleroderma. And of course, patients with diffuse type of systemic sclerosis will have quite extensive skin involvement. And so you can quantify the extent of that skin involvement, the burden of the skin involvement, by essentially just examining the patient carefully. And what has worked out for the purposes of a clinical assessment in clinical trials is if you assess the skin at 17 different sites on the body, which are highlighted on this mannequin here, and you grade each area of skin as normal, which would be scored 0, or mildly, moderately, or severely thickened, grades 1, 2, and 3, you can come up with something called the Modified Rodnan Skin Score. So this skin score essentially assesses the total severity of the skin involvement at that point in time. It's a relatively simple test, and in fact, once you've trained scleroderma doctors to do it, you can get reasonably reliable results, and it can certainly be used to assess patients. It can be used in clinical trials. The reason why it's been adopted as what's called a primary endpoint is the main thing you would look at in a clinical trial to get a signal that it was working in systemic sclerosis is firstly, of course, because of the ubiquitous nature of skin involvement, but also because it has for many years been appreciated that what's going on in the skin at least has some relationship with what else is going on in scleroderma. And I just show you here these graphs, which are taken from a paper that we published around 10 years ago now, that really confirmed again the link between skin involvement in scleroderma and other outcomes. And what we learned from this study is that if you were in a group of patients with diffuse scleroderma who had relatively mild skin and with standard treatments seemed to be improving over time, watched over the first 3 years of the disease, you had a significantly lower chance compared to patients with more severe skin of getting a major heart, lung, or kidney problem. So there's no doubt that if your skin is mild, you've got a lower risk. It's not you have zero risk, you have a lower risk of a major complication. The other thing that we learned from this study, which is perhaps even more important, and then certainly much more statistically significant, was that if you were in the unfortunate group of patients who had very bad scleroderma with very high skin scores, but that with standard treatments over 2 or 3 years, your skin didn't really improve, it stayed severely involved. Unfortunately, you're at much higher risk of having major heart, lung, or kidney involvement, and unfortunately, in fact, this is a survival curve, you were unfortunately at much higher risk of actually dying from your scleroderma complications. This was interesting, and again, it does speak to that link between skin and internal organs, because it suggests perhaps that if your skin couldn't improve with standard treatments, maybe the internal organs were not improving either. But what this study also showed is that it's not a simple relationship. You can't just look at the skin, and if the skin does well, say, well, the patient's doing well, or vice versa. So it does have its limitations, and you'll see that later in the talk. But if we focus on the skin, and this is where I wanted to start to now introduce this sort of background of clinical trials. And the first trials I wanted to talk about were really the trials that we've done and the evidence we tried to obtain just to support our current standard approaches to scleroderma. So we're rheumatologists, we're used to treating autoimmune inflammatory disease, and we're very familiar with the concept of using drugs to suppress the immune system, because in autoimmune disease, the immune system is overactive. And we know that in scleroderma, in the early stages of diffuse scleroderma, such as we see here, we know that if you do a skin biopsy, you will see inflammatory cells and immune cells focused around the blood vessels and within the skin. And we think that these immune cells in this early stage do trigger and drive the later fibrosis that occurs. So logically, if you could dampen down this immunological overactivity, you could improve the skin, you could improve outcomes. And this has really been the mainstay of the treatments that we've used for many years for scleroderma. And we've used the drugs that suppress the immune system that we're very familiar with in rheumatology from other diseases like vasculitis and arthritis. We've used methotrexate, cyclophosphamide, azathioprine, and a drug called mycophenolate mofetil Cellcept, or MMF. So all of these drugs have formed what we would call standard treatments for scleroderma. The new approach, which we're going to hear very much more about this afternoon from Dr. Burt, is of course the stem cell transplant, which is sort of taking this immunosuppression concept to the next level, and I will come back to that. But I wanted to first of all just talk about the recent evidence and the trials that we've been doing to try and understand better these standard treatments. Now, because they're standard treatments, it's very, very difficult to do placebo-controlled trials to see whether they're working. And so what we've done and what we have pursued in the UK and in Europe has been to do what's called observational studies. And these are the data published last year from the European observational study that was funded by one of the scleroderma charities in the UK and also by EULAR. So this was an international study. Dr. Disler was a participant in the study, and it was led from Manchester in the UK by Professor Ariane Herrick. But essentially what we took was we took more than 300 patients with early diffuse scleroderma, and we allowed the physician to choose one of the standard treatments that we use, methotrexate, mycophenolate, cyclophosphamide, or indeed to make the choice with the patient that maybe they didn't want to have an immune suppressive drug. And what we did was we then followed these patients for a year, and at 12 months we noticed what had happened to their skin score, whether their skin had improved or got worse. The clever part about this sort of observational approach is the statistics behind the results that I'm showing you, which is very complex, but essentially we use techniques to try and compensate at baseline for the differences between the patient groups, so that this was as close as we could get to a clinical trial without randomization, so that we essentially corrected the changes in skin score according to things like antibody profile, disease duration, gender, and so on, so that we really felt we were comparing similar groups. And so what you can see is that these patients all started off with a skin score of around, the average skin score was around 21. So these patients had significant, quite severe diffuse systemic sclerosis. Over the 12 months, you can see that either of the two front runners, if you like, treatments, most standard treatments, methotrexate or mycophenolate mofetil, overall the patients improved by 4 skin score units. And interestingly, is that is considered to be about, or considered to be the minimally clinically significant difference. So it's a meaningful difference at a group level like this. It's about a 20% improvement in skin score, and it's well outside what's considered the sort of error of the measurement. So patients did seem to improve on their standard treatment. But of course, they improved also when they were on no immunosuppression, and about half as much. So it was about 2 skin score units. But it wasn't that those patients who didn't have immunosuppression were much milder cases. In fact, if you look at just at the unselected survival analysis here, just up to 2 years, the purple group is the group of patients who elected not to go into immune suppression, and you can see that there's a clear separation, albeit with these small numbers not statistically significant, but I think we can see that those patients who are not on immune suppression seem to be well away from the cluster of patients that were being treated. So we feel comfortable that these drugs do make a difference, but clearly you can see from the numbers on the last slide, these are not curing the disease. But it does lead to the sort of concept that if low-intensity immune suppression of these drugs is helpful, perhaps very, very high-intensity immune suppression would be much more helpful. And of course, that's what Dr. Burt is going to be talking to you about after lunch. But I wanted just to share one experience, one patient with you, just to sort of really show that we do believe this. And I think, again, it's very strong support for the concept that immune suppression can be helpful. As you may know, there have now been 3 controlled trials, one of them led by Dr. Burt, all of which have shown that patients who do have a very high-intensity immune suppression that would be lethal if you didn't then have a stem cell transplant to rescue you, that they can do very well, and you can do better than with those lower-intensity immune suppression regimes. But what we've learned, at least in the UK in our centre, is that this is definitely not a treatment for everyone, because we, unfortunately, have had quite a lot of patients who have not survived the therapy and not lived, if you like, to reap the benefit. And that's, I think, one of the points about why we need to sort of try and improve treatment options. But I wanted just to share with you the case of Sarah. So Sarah is one of my patients. I've known her for more than 20 years. And I presented her a couple of years ago at a big rheumatology conference in the UK. But Sarah, I've known since the early 1990s, in fact, when she had a mild form of scleroderma with an antibody called RNP and what might be called mixed connective tissue disease with some minor changes in the skin. And things went along really. She had a family, she was doing very well in her career until around 2015, when there was a sudden change, in fact, and her Raynaud's and vascular symptoms got much, much worse. She had all of the standard treatments we use, sildenafil, prostacyclin, bosentan. But the thing that was very striking was that her skin suddenly became very diffuse. And I was interested from a research point of view. She developed a new antibody. She still had the RNP antibody, but she developed a very high level of anti-RNA polymerase antibody associated with diffuse scleroderma. And you can see how badly she did despite the normal treatment with MMF. And because she was getting so bad, and because we clearly got evidence that the immune system had sort of switched to a new gear with this worsening, we felt she was an ideal candidate for a stem cell transplant, and that's indeed what she had. And you can see, and I'm sure you'll hear similar data this afternoon. She did really remarkably well, and I saw her about a month ago, and she's now really almost back to where she was before all of this happened. So I think we're definitely believers that this is a very transformative treatment, but it is also a huge undertaking for our patients, and we would like to try and do things that were a little bit more precise, if you like. So what I'm going to move to now is really how I see that we can make real progress, and then present some of the emerging clinical trials for scleroderma. So I'm going to talk really about how we made progress, how we've tried to understand really the biology of the disease, how the inflammation and autoimmunity of systemic sclerosis link to the blood vessel abnormalities that we're very familiar with, and of course between them drive the fibrosis, and how those different processes interact. Because if we could understand that, then I think it would allow us to have a much more precise approach to treatment. So one of the things that I've been struck by in the laboratory work that we've done in our group, and also collaborating with Dr. Varga and Dr. Disler and others around the world, is that there are enormous similarities between the pathologies of scleroderma and the processes that occur normally in connective tissue and skin wound healing and wound repair. And I would go so far as to suggest that, in fact, if we think about how skin wounds heal, we see a lot of the events that are very, very similar to what's going on in scleroderma. We see interactions between the inflammatory cells, the blood vessels, and of course fibrosis. And here, this is actually a mouse skin wound, but you can see that when you have a full thickness skin wound, quite quickly the skin sort of regenerates over the top of the wound, but then subsequently you get this very inflammatory scar forming that is very contractile, and this has lots of activated fibroblasts and myofibroblasts in it that are very similar to the cells that we see in scleroderma skin and in internal organs. But the point that I'd like to really make is that in a normal process of wound healing in the skin, that process resolves essentially, and so all of these cells that are contracting and producing excessive scar tissue eventually melt away, and you're left with just a very small scar. Often almost normal skin regenerates. And so what we know is that this processes that are probably central to scleroderma are capable of reversing or improving if they were to be able to do what would normally happen in the context of something like a wound. So with that in mind, I'll sort of put in this table what might be called a shopping list of all the different factors and pathways that we know now from biological studies are really critical to wound healing and tissue repair and scar formation, that all may be therefore very, very relevant to systemic sclerosis. And I've just categorized them into proteins that are important in regulating cell function, the different cell types that are involved in the immune system, the proteins that are produced especially by cells of the immune system that can regulate other cell types, and the pathways within the cells that are thought to be very important in normal wound repair, normal healing. And because if we could think of ways of modifying these pathways, we could be perhaps well on the way to finding a treatment that could antagonize or help appropriately in scleroderma. So if you then take a sort of simple view, you can say, well, you can identify factors that are probably the bad guys in scleroderma that are really driving the disease process, and these you would want to downregulate. And I've just highlighted some of the candidates here, things like transforming growth factor beta. But you can also identify that there are the good guys here, and these might be the factors that are not working as well as they should. They might be suppressed in scleroderma, and if you could stimulate those pathways, again, you could get real potential treatment benefits. So you can see that color-coded. I'll come back to that in a few moments. But I just wanted to sort of say that this was the first approach that we had to try to, if you like, dampen down the fire in scleroderma and switch off one of the key drivers of the disease. So we've known for a long time that a protein called transforming growth factor beta is very potent at stimulating fibrosis, and it's important in scar formation. And so it was logical to think that this might be something we could block and therefore get benefit in scleroderma. And again, about 10 years ago, we did the first study, which was with a fully human manufactured antibody against one of the forms of TGF-beta, TGF-beta-1. So this work was undertaken and published just over 10 years ago now, and these were the results. And I said that we learned a lot from clinical trials, because one of the things we learned was that these groups in this trial were really not big enough to interpret the results, and we weren't selective enough in putting the patients in the study to really get interpretable data, because in the end, although there was the hint that maybe a higher dose was having a bit more effect on skin than placebo, there was nothing that was statistically significant. A few years later, and published in 2015, this sort of concept was taken further forward by Professor Bob Lafiatis in Boston, and he conducted again a study of a much more potent anti-TGF-beta antibody, Fresolimumab, and you can see here the results that he obtained. And this was a very short-term study, just with 1 or 2 doses of the drug. And what you can see is that there was a sort of transient improvement in the skin score, and there was certainly improvement in the skin biology that suggested it might be helping the disease. But unfortunately, there was no placebo control in this group, so we don't really know how the patients were doing compared to those that would not have received treatment. And so, with that sort of backdrop of the challenges of clinical trials, of how we do the studies, and what we've learned, I guess, from those previous approaches, I just wanted to now final part of the talk just to highlight just 6 examples. And I must say, you have got handouts that have my slides in them. The slides that I send over was a slightly more extended set because I obviously wanted to trim it so that I could fit it into the time. But I'm very happy to take questions if you've got any questions on any of the other things that are in the handout. But I'm just going to focus on 6 trials of 6 different drugs, and I've colour-coded them really according to what I just said, that they're drugs that are blocking things that we think are overactive in scleroderma, or they're drugs that are stimulating pathways that we think are maybe underactive in the disease. So I'll take you through these 6 trials. And the first, I'm going to first talk about the trials where we were trying to increase the activity. So these are, the first one is a trial of a drug called riociguat. So riociguat is actually a drug that is already available to treat pulmonary hypertension. It stimulates the nitric oxide pathway to dilate blood vessels in the lungs, but it also potentially has anti-fibrotic effects that could be very attractive in scleroderma. So here are the data from the analysis that we did just looking at the scleroderma patients within the clinical trials for pulmonary hypertension, showing that this drug definitely works. If you are on active drug, you actually improved your exercise capacity. If you're on placebo, things got worse, even over a relatively short 4-month clinical trial. So it works for pulmonary hypertension, but does it work for scleroderma, for skin, for lung, for other complications? So this is being tested now in a trial called RISE-SSC to see whether this riociguat drug in 130 patients randomized to either have placebo or active drug will do better when we look at endpoints like the skin or other relevant measures of disease severity. So the trial has now been completed and actually will be presented tomorrow, the top-line data at the Rheumatology conference. So that's one way of perhaps stimulating a pathway to stimulate this enzyme guanylate cyclase and increase and benefit scleroderma. The next pathway I want to pick out is another pathway that we've known for a long time that there is evidence that this pathway may be downregulated or less active than it should be in scleroderma and other forms of fibrosis. And these are pathways that are, you might call nuclear receptors. So these are proteins that are located within the cell nucleus that regulate expression of genes. And there's an important group of these proteins called PPAR proteins. And these have different forms, alpha, beta, gamma, and so on. So these PPAR proteins do seem to have reduced activity in, at least in scleroderma tissues and in preclinical models of scleroderma, and Dr. Varga and others have done a lot of work, and we've done work on this in our group in London, that really confirmed that if you have low levels of PPAR gamma activity especially, you seem to be very prone to fibrosis, and therefore logically if you could stimulate this PPAR activity you could improve the situation. So there have been a number of drugs that do this, and some of them came from diabetes mellitus, but they all had problems and they were all very selective for the different PPARs. The new drug that's now being tested is a drug called lanifibranor, and this is a drug that, unlike some of the others, stimulates all of the PPAR proteins, and we think that that may be more effective, but also may be better tolerated. And so this drug is now in a clinical trial called the FAST trial. So again, this trial is now fully recruited. It's testing 2 different doses of this drug, lanifibranor, to see if it is effective and what would be the right dose to use in scleroderma. And it's particularly looking at the change in skin score over a year, as I suggested. So this trial is fully recruited, but it's ongoing, and the results won't be known until early next year. We've got 2 posters at this ACR conference just presenting some preclinical evidence, at least in scleroderma models, that suggests that this might be an effective treatment, and others have done similar work in the past. And so this is a poster that one of my colleagues is presenting at the meeting, just showing that in a mouse model of scleroderma that gets very severe lung fibrosis, we can very clearly, in a dose-dependent way, show improvement of the fibrosis in the lung in this mouse model. And you can see, just as in the trial, we tested 2 doses, and you can see the low and the high dose having a better effect than placebo, essentially, in the mouse model. So that's exciting, but we'll have to wait a little bit longer for the results. And the final pathway of stimulation that I wanted to talk about is perhaps the most exciting in some ways, and that is the stimulation of cannabinoid receptors. So at least in the UK, there's a lot of interest in the sort of medical applications of cannabis, of endocannabinoids, and this important sort of group of molecules. So this drug, which has gone through various name changes, as you can see, it was given a number and then various names. It's now known as lenabasum, and I think that name will stay. So lenabasum is a synthetic cannabinoid, but it only binds to the CB2 receptor. So the cannabis has two receptors, CB1, which is in the brain, and that's what's responsible for the psychotropic effects of cannabis. But CB2 isn't expressed in the brain and is responsible for other effects of cannabis agonists or stimulation in the immune system, in fact, and in inflammation and fibrosis. So it was known for a while that that if you stimulate the CB2 receptor, you can stimulate PPAR gamma activity, relevant to the previous trial that I showed you, and you can downregulate some of these key drivers, CTGF or IL-6 in scleroderma. But most importantly, it seems that you can stimulate the natural parts of the wound healing process that are responsible for that resolution of wound that I showed you with the way the scar could melt away in normal situations. And so it's very attractive to think about doing that as a treatment for scleroderma. And in fact, a small early phase trial, such as I showed you in the schematic, just looking for some signal of benefit, has already been reported and completed. And this did look quite promising. And it looked at an endpoint called the composite response index, which is not looking for any remarkable change in one aspect of the disease, but it's looking across a range of things like skin and lung and how patients feel and function, and see whether there's a trend of benefit that, if you put it all together, could certainly be meaningful for patients. So based on that positive phase 2 trial, there's a phase 3 trial now, an ambitious trial of more than 350 patients that is ongoing, and hopefully will really answer the question of whether giving this agonist for the CB2 receptor will be beneficial. I should say, as I mentioned earlier, that this trial is one of those trials where you either receive the active drug or placebo, but you're allowed to continue with your standard treatments like mycophenolate, like methotrexate. So, really you're not disadvantaged by going into the study. Here are the data from the phase 2 study, and I'll say this is this composite response index, which just essentially makes a judgment as to whether you've got better or not during the clinical trial. It's a short trial, just 4 months long, but green is good, and you can see far more patients seem to look like they responded or improved on the active treatment compared to the placebo. So that's 3 trials that are turning things on that might be good. I just wanted to finish with 3 trials that are turning off things that might be bad. So I showed you what happened when we used sort of standard immune suppression, and the question really is, could we use a much more precise form of immune suppression to get more benefit? And so I just highlight this trial, which is the ASSET trial. So the ASSET trial is a trial testing another biological therapy called abatacept, which is already, again, in use for treatment of rheumatoid arthritis, but blocks the immune system in a very specific way. It blocks what's called coactivation, so the way that the immune cells talk to each other to induce an immune response or even to induce autoimmunity. And so this is a drug given by injection once a week, and the trial treated patients for a year. It treated 86 patients, half with drug, half with placebo, and it looked to see whether there was benefit in relevant endpoints, including the skin. And again, this is a trial that's going to report its results at the conference, in fact, again in the session tomorrow. So that would be turning off the immune system in a very precise way. But if we move further down into the sort of scar formation in scleroderma, it's very attractive to think we might be able to turn off some of those pathways that are driving fibrosis. And there is a drug called nintedanib, which is already available as a treatment for lung fibrosis, idiopathic lung fibrosis, which we think has real potential in scleroderma as well. So this drug is already available, and it's now been shown, at least, and Jörg Dissler undertook some of this really pivotal work to show that it does seem to work in mouse models of scleroderma very effectively. And so it's now being tested in what is so far the largest trial that's ever been done in scleroderma, 520 patients with lung fibrosis in scleroderma, to see whether or not this drug is superior to placebo. And if it is, because this is a phase 3 trial, we will hopefully then get access to this, and it may be a drug that's licensed for scleroderma for the skin, and maybe even for the lung, and maybe even for the skin. So I just want to finish with the targeting of the IL-6 pathway, because that's another area I think that's been quite exciting in the last 2 or 3 years. So again, worked from a number of groups, but we focused a few years ago on IL-6 in our laboratory, because we were very interested in the fact that we'd identified that patients who have high levels of IL-6 seem to be doing particularly badly, and if you stained their tissues for IL-6, you could see high levels of expression. We particularly found that this IL-6 seemed to associate with those patients who had bad scleroderma skin that didn't improve over time with standard treatment. So we thought those patients might benefit from blocking IL-6. And blocking IL-6 is already feasible because there's a drug, again, for rheumatoid arthritis and vasculitis, which does just that. It's a drug called tocilizumab. So we had a lot of discussions, and eventually a clinical trial was performed, and this was the Fascinate clinical trial, which took 86 patients and randomly allocated them to either have tocilizumab or placebo. And it did really fulfill what we thought might happen. And you can see here are the data for the skin score changes during the 48 weeks of the study. If you were on the active drug, you can see your skin score certainly fell during the 48 weeks. And if you were on placebo, it didn't really seem to fall as much. This was interesting. It was small numbers. It didn't quite reach statistical significance. But when we looked at other signals, such as the biomarker, the gene expression in the skin, that did certainly change. Even at 6 months, that was significantly downregulated by the tocilizumab. And unlike in the fresolimumab study, we had a control group, so we knew that this was something that the drug was doing. And most importantly, we found that this drug seemed to really prevent the decline of lung function in this patient group. So it seemed to be a sort of unique situation where it was helping or preventing the progression of lung disease. We were interested again, and I think one of the opportunities we've had from clinical trials is that we can sort of take samples from those trials, patients consent to allow us to study them and understand better the disease, but also what the drug's doing. And we were very fortunate because we got fibroblasts and grew fibroblasts from the biopsies of the patients in that Fascinate clinical trial. And it allowed us, first of all, just to confirm, here's a gene expression plot, that the scleroderma patients are clearly different from healthy, normal fibroblasts. And you can distill that down into a sort of pattern where you've got upregulated genes in red and downregulated genes in blue. And as we might have expected, this was dominated by this activation pathway of TGF-beta. But what was very exciting was that we could also compare the effects of tocilizumab, which really downregulated many, many genes, more than 2,000 genes. But we were interested in the fact that many of the genes that were downregulated were genes that were abnormal in scleroderma. And you can see here that what the drug actually did, if you look at that's the average scleroderma baseline pattern, that's what the drug did. It downregulated those upregulated genes, and it upregulated the downregulated genes. And again, we had a placebo control that showed that that didn't really do very much at all over 6 months. So all of that led to the FOCUS trial, which was a larger trial to try and see if we could confirm those effects on skin and lung for tocilizumab. And again, that will be presented tomorrow. So I've said that will be presented tomorrow for 3 of these trials, and clearly the full results are under embargo, but fortunately the abstracts of these trials are published online, in fact, about a month ago, and so we are allowed to at least give the level of detail that is in those. And I just wanted to give you a sneak preview here of some of those results, and really also to sort of measure expectations a little bit. We're still learning how to do clinical trials because just for simplicity, green is good, and you can see that there's quite a lot of green here, which means that the clinical trials really showed what looked like quite promising effects on function, on this composite response index in scleroderma and lung function. So there's certainly evidence that these drugs do something in the disease. What has been very challenging is it's been very hard to show consistent benefit in the skin, perhaps because the disease is so diverse. So really, just to conclude, I wanted to give you, this is my conclusion, the state of clinical trials in scleroderma. So we have the starting point that really it was a very desperate situation sort of 20 or 30 years ago, nothing seemed to work. We understand now much better how to do the clinical trials, choose the best patients, measure the best endpoints. The trials are in helping us to understand more about the disease biology.
And we've perhaps got to this point, and I just showed you on that previous slide, that we've got almost positive trials from drugs that almost certainly work. And that's a much better place to be in than where we used to be, but it's not where we need to be. And we now need to sort of take things to the next level so that we can really finally get trials that will be sufficiently robust that we can easily get regulatory approval for these drugs, and that's going to be the next challenge. So I will finish there. Thank all of the people in our centre at the Royal Free and my collaborators, and very happy to take questions. Thank you.